This is a public conversation on opioids addiction and the quest to save lives. Now, 4 months ago, Lauren Mandel came to see me in my office in Newburgh. She had just buried her 22-year-old son, Zane, who died after taking opioids. And as a representative, she wanted me to help her do something to help prevent a similar tragedy from happening to anyone else. So, not one more. Ladies and gentlemen, America is addicted to opioids, and the number of deaths is rising every year. Last year, 64,000 Americans died from opioids overdose. My community is addicted to opioids. Across Orange, Dutchess, and Ulster County, which I have the honor to represent, 174 people died after taking one or more opioids in 2015. And across New York State, the number was 2,771 in 2015. The loss of life due to opioids is higher than the loss of life caused by homicide, traffic accidents, and suicide combined. The problem we are faced with as a society is both simple and complex. It is simple because its causes are known and these deaths are preventable. It is complex because to preserve life and improve the wellness, the well-being of others in our communities, in our state, and in our nation, we must face both our cultural biases and our legal system that has prevented us from making use of solutions which have long been known and available to us in preventing further harm. So once again, not one more. While many similar forums have occurred here and beyond, we can never have enough discussions on this important topic that is tearing our families and our communities apart. And that's according to Linda Mueller from the Cornerstone Family Healthcare Center. So today is a good day to take on this cause, even though we are competing with the Women's March in New York City and Washington and beyond. Good cause, a great cause. We are all gathered with people who devoted their lives to understanding this problem from a series of distinct perspectives, and together, these perspectives from a fuller, more complete view about America's addiction to opioids. Our speakers include research neurologist, a lawyer and a former New York City police officer, a drug police expert, a harm reduction specialist who works with people who use drugs, and an analyst of local public health data. Over the next 2 hours, we will hear the speakers discuss many aspects of this problem. The conversation will be guided by questions developed collaboratively by my office, the organizations that co-sponsor this event, and residents. This is a public conversation for the benefit of the community, and I hope that you will respectfully speak up and ask questions throughout the discussion. After the discussion, we will have until 5 p.m. to converse with the speakers and each other informally. I want to take this opportunity to thank our local co-sponsors, Cornerstone Family Healthcare, Hudson Valley Community Service, Team Newburgh, and United Way of Dutchess Orange Region. Our state co-sponsors, Drug Policy Alliance and Vocal New York, especially N.G. Woody, who's in the house, a policy analyst and organizer who worked closely with my office to produce this event. And I also like to thank the people at the Newburgh Armory Unity Center for letting us use this space, and for helping us set up. And of course, my staff, Alex, Steve, Chris, and Jill, who did all the work for me. Ladies and gentlemen, we are only as good as the people we have working for us and with us. So, as you can see, this forum features many speakers and relatively little time to get it done. I will now ask our panelists to please spend 1 or 2 minutes each to introduce themselves, starting from my left. Thank you. And give a round of applause to all of you for coming and everyone for participating here today. Thank you.
Good afternoon. My name is Vincent Trunzo. I'm a counselor at the Center for Recovery.
Is the mic on?
Testing. So I'm the counselor for the Center for Recovery, and it's here in the city of Newburgh. And I want to thank Assemblyman Skartados for this event here. That it's 5 or 10 years ago would have been unheard of to have such a conversation. So thank you.
My name is Lauren Mandel, and I'm the person that walked into Mr. Skartados' office to talk about my son Zane. And I too am very grateful to be here today, and I'm looking forward to this conversation.
Good afternoon, everyone. It's nice to be in another part of New York. I didn't realize I've been in New York for 20 years and I've never been here, so I'm happy to be here. I'm Carl Hart. I'm the chair of psychology at Columbia University. I've been studying drugs for nearly 30 years now. It's hard to say why you're here or who you are. I'm also a drug user. I also have worked with people who are addicted to drugs and that sort of thing. So I have a lot of sort of hats that I'm wearing here today.
Hi everyone, my name is Kassandra Frederique. I am the New York State Director at Drug Policy Alliance. Drug Policy Alliance is a national organization that works on ending the war on drugs. And we do work from everything from working on sentencing reform to increasing access to services to people that are using drugs. And we do a lot of work with Vocal New York, which is another group, statewide group in New York State that works with directly impacted people.
Thank you. Good afternoon, everyone. My name is Jeff Kaufman. I'm a former New York City police officer and an attorney for the police department, as well as an attorney for indigents through my career. Currently, I am a high school teacher. So talk about diversity in work. I've seen over the last 30, 35 years an incredible change in the use and in the reaction by law enforcement to the use of drugs. We have, I represent an organization called Law Enforcement Alliance Partnership, or LEAP, which advocates the complete end to prohibition and the legalization of all drugs as a solution to the issues that we face, not only in terms of opioids, but in all drugs. And the fact that by creating a black market, starting actually at the turn of the century, but more specifically under the Nixon administration, that we've in fact created a police response and a criminal justice response to a medical issue. And without this, the eradication of prohibition, we're never going to stem the tide of opioids and other drugs that people are affected by.
Testing. Hi, everybody. My name is Frank Barone, and I am a syringe exchange prevention specialist with Hudson Valley Community Service. Just want to start off by saying I'm honored to be here, and hello? We offer our clients a number of services. We, the syringe exchange, we provide them with sharps containers, so they can bring their used syringes back to us. We also provide Narcan training and the Narcan free of charge. We do HIV testing, ASC testing, and if they need a referral somewhere else, we can help them out with that too. They need treatment. We also provide a snack and a bottle of water each time they come, because sometimes that's the only thing that our clients get to eat all day. So, like I said, it's a real honor to be here. Thank you.
Okay. Thank you, ladies and gentlemen. We have one more.
My apologies,
Sergeant,
sir.
go ahead. I'm sorry, I didn't see you.
No,
Come on up.
it's a camouflage in the back in the corner.
I
You probably
see.
didn't see me.
Very good.
It's right. So, my apologies. My name is Sergeant Fernandez. I'm with the Counter-Drug Task Force with the National Guard. My mandate is to aid any local coalitions in their internal structure and development, as well as foster an atmosphere of communication between agencies. Our efforts are data-driven, and to understand a problem well, you have to know what the problem is, where to combat it, and where to put your resources. This stems through not only local coalitions, but law enforcement as well. So the collaboration between interagencies is essential, not just for combating the street-level narcotics, but the systemic problem of addiction at its core, and providing people like the local coalitions to have avenues for prevention to stop a problem before it occurs. This cannot happen unless you know what the problem is. So that is why I'm here, and I'll be hiding in the corner, so if you need me, just, yeah.
Well,
Oh, yes. The reason I'm in the corner is due to military protocol, I cannot stand on any board or tasking such as these gentlemen. So it's an honor to be with you guys today. I do not speak for the Army. I speak as a facilitator through agencies. And that's why I'm over here. I didn't do anything bad or get on a timeout or anything, so.
well, thank you all, ladies and gentlemen, for your introductions, and I'm looking forward to your insights. This is really great turnout, and this is a testament to the importance of this topic. So I thank you so much for being here, panelists, as well as audience. How about another round of applause for yourselves? Yes, thank you. Now, to frame the discussion, we will begin our forum by hearing a brief presentations from 3 speakers. And Lauren will start by telling us about her son, Zane. Lauren, you have 5 minutes. Please go ahead. I'm stickler.
Thank you, Assemblyman Skartados, and forgive me, I have to read a little bit, for inviting me here today, and more importantly, really for the kind way that you treated me in September when I stopped by the office. I just stopped by to set up an appointment to speak to Mr. Skartados, and his office staff just literally stopped what they were doing and brought me into the back room and met with me. And I'm sure they were doing very important work, and they just stopped and they met with me. There's no word to describe me now. I'm not a widow. I'm something worse. I'm something nameless. I'm the mother of 2 sons that only has 1 living. I am what all parents are afraid of and afraid to be. But this is my now because I live in a world that has before and after. My world before consisted of a 25-year career as a registered nurse specializing in mental health, substance abuse, and community health. I developed the policy and procedures that were used at the same substance abuse program that my son attended over 15 years ago. I have developed a curriculum with a panel of brilliant women sponsored by the DEA and the INL called The Grow, guiding the recovery of women. And I went to South Africa to teach a train the trainer for non-government organizations. So I was very aware of substances and abuse on a very professional level. My family also has a strong history of substance abuse and gratefully recovery, so I have had a personal perspective as well. My sons were raised in a feminist household with women who loved and cherished them. My father and brother are both in recovery, and they shared their stories freely and openly with my sons, and especially with Zane. Because I knew I had to watch Zane. And I commented to a friend when he was about 11, as he excitedly walked up to an open bar. We were at a ranch, a dude ranch for the weekend, and they had an open bar for about an hour. And he excitedly walked up there and ordered 4 root beers and lined them all up and sat down and chugged them. And I said, wow, he's going to get a room. He has a chair reserved for him in the 12-step program someday. So I knew, I was worried. And it was with that watchful eye that I had then and we always had condoms in the house. We had Plan B in the men's bathroom downstairs because I knew the deal. I knew that young men have sex. I know that they try drugs. I know they drink. But we would talk about it and sometimes fight about it. I even took the Narcan training at the local library because I thought I should have it in the house, not for my own children, not for my son, but for all the other children that come into the house because I know the deal. We spoke about these issues in our family, and our family friend, I'll call her Marcy, she grew up with abusive, drug-addicted parents who sadly became addicted to heroin. The children knew about my friend and struggling to get her away from an abusive drug dealer who whored her out and burned her with cigarettes. About midsummer, I even told Zane about a childhood friend of his that died of heroin overdose the year prior, a smart, pretty girl with every disadvantage possible, poverty, mentally ill parents, emotional abuse. And Zane, my son, said, junkies are hard to help. Now this is the after me and my family live in. All of my beliefs about drug use and abuse have been shaken. I don't know what the answer is. I do know that the system that I tried to access for my son failed. Really important people in Orange County have told me that that's not correct. The system did work. It's just that addiction is addiction and it can kill you. I don't agree with that, and I believe they are wrong. I am encouraged by the ability to begin this confusing dialogue today, and I look forward to progress.
Thank you very much, Lauren, for your testimony. You're a very courageous woman. I don't know what I would do if I lost my daughter, who's now graduated from high school. So thank you for being here, and thank you for your testimony. And next, we will hear from Sergeant Fernandez about how common experiences such as Zane's are, as well as other occurrences of addiction and opiates abuse. Sergeant, you also have 5 minutes to present us with information on the local scope and trends on the opioid use, addiction, and overdose. Thank you, sir.
Thank you, sir. First, stand up. Okay. I'm sorry, I have to stand up. So first, let me say one thing about data before I proceed. Data can be used 1,000 different ways from 1,000 different lenses. So keep your mind open. Remember, these are raw numbers, and they can lead down 1,000 different paths. And just because the data is where it is not an answer to the question of why we're collecting it in the first place. Now, we have a live feed in St. Luke's. So every time the use of naloxone occurs within the city, we know about it. We know more or less where it came from, where the ambulance came from, what zip code it came from, and it led us into some startling realizations. First, since April 6th, we've had 181 overdoses hit St. Luke's doors. With the use of naloxone, we have over a 90% survivability rate. That seems on its right an amazing number. If your child comes to you right now and says, I got a 90, 92 on my test, I'm pretty sure every parent here, minus the ones who are a little bit more strict, are gonna enjoy that number. They'll be like, wow, you're doing great. Unfortunately, that means we lost 13. And this kind of fight, 90% doesn't cut it. 95% doesn't cut it. 99.9% doesn't cut it. Because that leaves one person on the panel grieving for a loved one. That being said, the data does offer us insights into our city and what we need to do. Only 50% of those calls originated from within the city limits. That means over 50% were outside the city limits. Now, from that 50% that are within the city limits, we do not know if they're residents of Newburgh. And you can look at the papers, you can look at the numbers and say, well, Newburgh has a massive problem. No, the region has a massive problem. The towns connected to us have a massive problem. Our counties, our state, our nation has a massive problem. And just because the numbers say that this city is bad, you all have to open your eyes and say we all have a fight. And we all have a word and a conversation within this conversation. Sergeants don't like clapping, don't worry. That being said, our numbers also show dips in certain cities. Newburgh's last year, through the N.Y.S coordinator, has a dip, a drop, in the amount of naloxone administered within the city limits. Unfortunately, Kingston, across the side, has a rise. Middletown is down compared to last year's numbers, but Port Jervis is up. This epidemic is bouncing from city to city, location to location, and users are tracking dealers. What the data offers us, what we do, is not the solution. It provides tools for the people that are doing the work to collectively place their resources, collectively enter in conversation to fight the fight that needs to be done. That being said, your local coalitions, your prevention specialists, they need to know what the situation is before it happens. This epidemic hit us 2 years into the making. Now imagine people start talking now about an epidemic that happened 5 years from now, not the other way around. And we start trying to solve the situation before it occurs. That's what data provides. Data provides the means and ability for you to understand your situation and combat the situation where it is and when it's supposed to be combated. Now I can go through numbers all day long, and I'll lose pretty much half of you, and about half an hour later you'll see me starting to do this because it's kind of dry. So I'm not going to go into exact numbers in detail. If you wish to know exact numbers in detail, by all means, we do not hide numbers. We do not guard information. Ask us what we have, we will provide it. If you want Narcan trainings about numbers in your specific area, ask us and we will provide it. But more importantly, get a hold of your local coalitions. Get a hold of the people who are on the street trying to help out and find out how you can help out. Maybe it takes one person to talk to one person at the right time, and you can't do it unless you actually stand up and do it. That being said, I don't want to be too speechy. The Army's not known for speechy. So thank you very much for your time. I don't want to keep any hacklines, but if you need more information, if you need data, if you need something, I'm not hard to find. I'm the only one in uniform unless I'm hiding in the corner in the back. Thank you very much.
Thank you, Sergeant Fernandez, on your presentation on the local scene. Appreciate it. And now I will ask Dr. Hart to tell us what he and other scientists have discovered about drug use and addiction, how these findings fit with long-standing government policy, and which policies would best facilitate health, safety, justice, and social harmony in New York and elsewhere. It is a lot to cover, and Dr. Hart will have 15 minutes to make his point.
Thank you for your generosity and the time. I'll stand up. You all should know, last night, every Friday night, I teach in Sing Sing. And so it takes me some time to decompress and to recalibrate to be back out here. In part because of what happens in places like Sing Sing when you see a place like Sing Sing, 1,600 men are there, mostly black and brown, and the society has forgotten about them. And then when I go in as a professor and engage folks, and they engage at this high level, and even better than some of my Columbia students, it takes me some time to recalibrate. So please forgive me in terms of how my demeanor might be at some point. But I'm happy to be here, and I'm here because of Alex. Alex really hounded me, and he got my cell number and texts me regularly. So mad props to you, Alex. I'm happy to be here. I'm happy to be in spaces where people are trying honestly and genuinely to solve this issue. I say honestly and genuinely because oftentimes that's not the case when we talk about opioids. It's so much rubbish that it's talked about in these spaces, and we're going to try and make sure that doesn't happen. In order to make sure that doesn't happen, I just have to take you back history. At the turn of the 20th century, what we're going through now, they were going through. The typical opioid user was a white woman who was between the ages of 30 and 50 years old. She got her opioids from Sears, Roebuck and Company. So this is not new. So when people act like this is new, you can stop listening because they think you're an idiot or they are an idiot. So we need to keep that in mind. And two, when we think about opioids or we talk about this subject, we have to understand why people use opioids. Opioids are really good drugs to decrease anxiety. They produce euphoria. They decrease pain, emotional pain, psychological pain. They're really good at that. They induce sleep. It's not a surprise that people like Philip Seymour Hoffman loved his opioids. The kind of pressure that guy must have been under. It's not a surprise that Prince loved his opioids, the kind of pressure that guy must have been under. This provides a clue in terms of how we best help people, how we become a better society. People who are using opioids are not stupid. They're using them because they work. And opioids are not the devil drugs. They actually work. They've been around. They've been around longer than most of our medicines. And so if we understand that, that helps us to have some compassion and also some information, education. Now, to that point, we have to understand too that much of what is said about opioids is exaggeration, is hysteria. Now, it's true, people are dying. I have lost very close friends. I have lost lovers as a result of opioid-related deaths. So I understand the real deal. In 2015, I went to Switzerland. I worked in an opioid clinic, a heroin clinic, where we gave heroin twice a day, every day, 7 days a week, to people as part of their treatment. And they've been doing that for more than 20 years in Switzerland, and it works. Those people who are in that clinic, most of them have jobs. They're happy, but they also have other services, psychological services. They have a psychologist, they have a psychiatrist, they have a nurse, they have a social worker. They have all of these auxiliary services because the Swiss care about their people. That's why they have those sorts of things, and it works. So when we think about drugs like heroin, heroin's not an evil drug. It's a drug that's used in medicine if you do it right, if people have the education. So now we have to ask the question, why people exaggerate this issue? Why the hysteria? Well, the hysteria helps to bring us in the room, so we understand that. But we also need to know, though, that when we hear numbers, like, for example, the 64,000 deaths numbers, that's not 64,000 deaths from opioids. That's everything. Antidepressants, acetaminophen, all of those overdose or drug-related deaths are there. When you separate the opioids out, then you get about 33,000. That's the latest CDC numbers that I have seen. And then when you say 33,000, you say, well, every year in the United States, we have 35,000 deaths from automobile accidents. Are we talking about banning automobiles in this country? Of course not. It would be ridiculous. But what we do is we say that we have to make sure people have the education and the know-how to drive. And we ask people to wear seatbelts. And we have speed limits. We take these rational steps to deal with a potential risky situation with things like automobiles. And then when we separate heroin out of that number, we find that about 13,000 Americans die from heroin in that latest number. More people die, of course, from handguns, 15,000, 17,000 a year from handguns. But we have lumped all the drugs in there to make you get fearful. And it's okay if we come in the room, we have to come in the room with some sense, with some logic, with some cool-headedness so we can tackle this problem in a logical way. Now, that said, when we think about the solutions, the thing that we know is most of the people who die from an opioid-related deaths do so because they combine the opioids with another sedative, alcohol, a benzodiazepine, the other antihistamines. These other sedatives make it more risky, increases the risk of respiratory depression. What that tells you as a solution, you tell your society, you tell people who are using opioids, don't mix it with another sedative. You make sure you identify what these sedatives are so the drug users and people will know what they are. Because it's not a simple thing to do, that is to die from a single opioid alone. That's not a simple thing to do, but if you read your newspapers, you think it is. Another solution. One of the things that we're worried about now is this drug called fentanyl. Fentanyl is more potent than heroin, simply means that a smaller amount of the drug is required to produce an effect, and that effect can be respiratory depression. So if someone thinks that they have heroin and they take the fentanyl at the same dose or amount that they would use heroin, they can die from an overdose. Because sometimes people, when they buy drugs on the street, they don't know what the drug contains. They don't know the adulterant, and fentanyl might be there. There's a simple solution. They do it all around the world. They have anonymous free drug checking services for their people. Very simple. We have that technology in the United States, but we have not made it available to people. So when people tell you that they care about your community and they don't do these simple things, you have someone before you being disingenuous. This is very simple. I mean, we have included Narcan, we've done those sorts of things, that's great. But you can do these other things, and these other things will also help ensure that your population is safe. Of course, in life, there's always risk. Every day, people are dying. But these things will certainly make the risk-to-benefit ratio more favorable. And finally, we must also separate people who are addicted from those who just use drugs. The vast majority of people who use opioids are not addicts. They're simply using opioids. And so we don't want to lump everyone into the same sort of category. People who are addicted, they need our help, of course. And our help should be tailored to fit their needs. But if we just lump everyone into one category, we're not doing that. Thank you all for your time.
Thank you, Dr. Hart, for setting the record straight. And it seems to me we have to stop the war on drugs and perhaps begin peace. Yeah, you can clap if you like. So at this point, what I would like to do is to first open the discussion to the rest of the panelists and give each of them a few minutes to comment on anything that has been said so far. Priority given to saving lives, keep that in mind. But first, I also like to give some guidance to the audience as to where we are going. After the panelists have had an opportunity to speak, we will ask members of the audience who wish to ask questions to please raise your hand, and one of our aides will bring you a microphone. I also may have a few questions of my own to ask the panelists, but I would always yield to the audience. And thank you so much, audience, for being here with us and participating with us. Audience, all together, not one more. Not one more. Okay, we'll do better the next time. So, to the rest of the panelists here, any comments about what you've heard so far? We can go from right to left.
Okay, so when I was listening to this woman's testimony over here, about her son, it got me a little teary-eyed. I started using drugs when I was about 12 years old. Marijuana and alcohol is what I started with, and then it progressed to hydrocodone. And I did my first rehab actually when I was 12 years old, and second one when I was 15, another one when I was 16. Using Oxycontin when I was 16 years old, and they made them plastic. They made the pills actually plastic, so you couldn't inject them or sniff them anymore. So me and my friends, we all started sniffing heroin instead, and that slowly. You start sniffing it for a while, and eventually, it doesn't get you high anymore, so you inject it. And before you know it, you're on your knees, and you're addicted. And I got 3 years clean coming up soon, and I've had like 15, I've been to a lot of funerals. sorry. I've been to a lot of funerals in the past 3 years, probably about 15, and it seems like this the epidemic isn't getting any easier. It's, I work for a syringe exchange program. I work for a syringe exchange program, and I work with addicts that are in active addiction, and we do Narcan training, and we give out a lot of Narcan. And people come back and like, oh, I used it, and it feels good. It feels like you're saving lives every day. But people that I was in rehab with or in jail with, a lot of people that are in recovery. I mostly notice with people that are in recovery that go back out and they it's fentanyl stuff or they use too much and they pass away, and it's just really difficult. So I feel like as a community we need to all work together and just need to work with people where they're at and be compassionate, and just people are ready when they're ready. And I've had somebody friend overdose 10 times in his life, and now he's got about 4 years clean. So it's hard. People say, oh, why don't they just stop? It's not that easy. So that's all I got.
Thank you. Thank you.
I know I don't look that old, but I actually remember when the Rockefeller drug laws were passed. I was in college at the time. And after the Rockefeller drug laws, I had no idea I'd end up in law enforcement. But in the late 70s, I decided to join the police department in New York City and was assigned immediately to an area of Brooklyn that at that time had, I think, 6 times, that one precinct, the 7-5 precinct in East New York, had 6 times the number of homicides that the whole city has now. So you can imagine what that place was like. And it was strewn with heroin. This was before crack really started to get going. That took a few years after I was on patrol. And I saw the impact that heroin had on this minority neighborhood, African American and Hispanic, totally. I saw the experience in terms of criminalizing drugs and criminalizing, in this case, heroin. And I just as an aside, at that time, the heroin, the concentration of heroin was, by today's standards, extremely weak. The price was very high in comparison to today's standards as well. All of those things changed because of the criminalization of the substance. And what happened when crack came, crack also affected the same neighborhood that I patrolled in Brownsville and in Bedford-Stuyvesant. That at that time in Bushwick, the issues were the same. Heroin started to go out, crack cocaine started to come in, and the number of deaths and overdoses, but more importantly, the involvement of the police department in what is basically a medical problem persisted. In fact, when I became an attorney, when I was in the police department, I was assigned to the legal bureau. I was counsel to the police commissioner at that time, Benjamin Ward. And I was put in charge of seeking forfeiture of drug proceeds, which meant that people and mostly people who were addicted and involved in the criminal justice system, who had some property, we would seize it. And we would seize it, put that money into the city coffers, and then we would buy expensive police surveillance equipment to make more arrests. The problem never stopped. The drugs got more concentrated, the deaths increased, and by the time I left the police department, I ended up working in the family court system, watching families get destroyed, children being removed from parents for being suspected of using drugs. And then as time went on, and now I'm moving into the 90s, early 90s, I actually had the opportunity to teach in Rikers Island in the prison. I taught there for about 8 years. Absolutely incredible, the perspective, as Dr. Hart just said, from Sing Sing. Who is in Rikers Island? Why are they there? What is the issue besides the concept of lumping, attaching criminal justice, criminal convictions and the stigma of a criminal conviction, basically disenfranchising and keeping out of society people who are attached to this. So in the early 2000s, I became aware of a group of former police officers and other law enforcement people who had some experience with drug interdiction and arrests like I did for drugs, realizing criminalizing it is not the way. That it actually caused the problem. It did not solve the problem. Now, I know that we are dealing here with a lot of personal issues, and I'm not trying to minimize any of them. But I will tell you, if we attack this in a more concerted, policy-oriented way to prevent this from involving the criminal justice system, not only will treatment be available easily, but as a society, we'll be able to plan how to deal with this problem in a way that does not stigmatize people and future generations in terms of dealing with this. We've had no success in this war on drugs. In fact, what would it actually be to win this war on drugs? Nobody's ever said that. And the only thing I can add to this in this point is that I'm a living history of the fact of this failure of this drug war. And the fact that we're at this point now, and I'm here in Newburgh, and I thank you for inviting me, the fact that I'm here dealing with the same problems that I've dealt with for the last 35 years is no accident. It is a total product of the way in which we deal with these substances.
May I? Just 1 second. Thank you, Jeff, right? Thank you, Jeff. And I want you to know that we in the New York State Assembly a few years ago led the effort in the fight to decriminalize the Rockefeller drug laws, the stop and frisk policy, and increasing the age and so on and so forth. And we continue to bring justice to our justice system. So I appreciate your testimony. Thank you.
So who wants some solutions? Wants to figure, okay, because I see this crowd over here that's like, let's get to the solutions. So here's the thing. There are so many ways, there's a lot of history here about how we've been in this situation multiple times. But one of the things that we know often is that the conversation, something that Carl Hart brought up, was that most people don't realize that a lot of these overdose deaths are happening because people are mixing substances, right? So that using one opioid, you can die from that, but it's actually a lot easier if someone is mixing substances. But people don't really recognize that. So when we're talking about how do we end the overdose crisis here in New York State, there are things that we're missing in the conversation. One of the things, and as someone who is a social worker, right? One of the things that we realize when we talk about substance use and we talk about people stopping, getting people to stop using drugs, one of the things we don't talk about is that we've had the tools to help people with opioid addictions for over 50 years. Do you know what I'm talking about? Do people know what methadone is? I do. Right? Methadone, right? So methadone, do people know what buprenorphine is? Suboxone? So medication-assisted treatment is actually one of the most successful ways to deal with opioid addiction, right? It is actually one of the ways that cuts the fatality of opioids by 50%. And Savelives, who's written a book called Unbroken Brain, consistently talks about the need and the usage of medication-assisted treatment. Do people in this room know where you can get methadone in Newburgh? How many people know?
Show of hands.
You're on the panel, so that's cheating. That's not enough people. Do people know where you can get access to methadone or buprenorphine in Newburgh? Doctor's office. But if someone came up to you right now and said, I need methadone, I need buprenorphine, could people name the doctors or the places that they can get it? That's a problem, right? How can we end the crisis that we're in right now if we don't even know where the local resources are, right? Or if we don't even have access to methadone or buprenorphine. There are places in New York State that they have to, so for example, I went to college in Ithaca, New York, right? If someone in Ithaca, New York wants methadone, they have to take a Medicaid paid cab to get to Syracuse, which is an hour away, to get on a waiting list. that is 9 months long. And that's if they have Medicaid. If I need methadone today, then I need to get methadone today because I might not have it tomorrow. Does that make sense? So the conversation here is how do we talk about the access points for medication for people that are struggling with opioid addiction? Where are the resources in town? And who has access to them? How many people in here are trained for naloxone? Again, not enough people. How many people know where they can get trained for naloxone? How many people know where naloxone is? Are your local elected officials doing naloxone trainings in your neighborhoods? I'm not talking just about your assembly members. I'm talking about your county legislators. I'm talking about your mayors, your town supervisors. They're not doing it. That's a problem. Not enough. And that is a problem. So every time there's an election season and people put, I'm going to end the opioid crisis, but they haven't done one opioid reversal training, that's bullshit. People are dying for no reason. You can reverse an opioid overdose. But people don't have naloxone in their bathrooms. And if they do, they don't know how to use it. People are crying for treatment. But so many people are addicted to this idea that addiction and recovery works one way. That it's cold turkey. That you can't use medication. That it's tough love. That you have to hit rock bottom. It works for some people, and it kills others. Right? It's true. And it kills a lot of people. So if we're talking about, if you know someone who is using heroin, is injecting, how many people know where that person can get an unused syringe? No one. There's not that many people in this room that know where they can go to a local syringe exchange. Do people know what a syringe exchange is? No. Okay. Because you work there, can you explain what it is for people?
So basically the way our syringe exchange program works is we have 2 mobile vans. One does Monticello, one does Newburgh, one does Poughkeepsie, one does Kingston. And what we do is we, have clients come and sign up. It's anonymous, so they don't have to give their name or show ID or anything like that. They just give us their initials, date of birth, and basically we give them clean syringes, sterile syringes for one-time use only, based on how many times a day they're using. And we give them sharps containers, and they put their used syringes in the sharps containers and bring them back to us, and we dispose of them properly. And that's basically the syringe exchange part of it. Like I said before, we do HIV testing, hepatitis C testing right on site. We also give out sterile drug-using equipment, which is like cookers, cottons, sterile water, bleach, in case they have to use a syringe twice, or a friend has to use it, they can clean it. And that's pretty much it.
I'm sorry, I don't mean to cut back from the corner. It just was very striking when I saw the amount of hands down when they said they didn't know the resources in your own town. That shocked me because every day I work with people who provide those resources. So real quick, if your hand was down, if you're part of Team Newburgh, you have SALT in the back, Love Agency together. You have HVCS in the back. If you guys just raise your hands. Team Newburgh, if you guys can stand up real quick. These are your local coalitions in your town. They're dedicated to spreading the information that you said right now to the people that you're sitting next to you left and right. Reach out to them. They are vigorously on the streets doing street outreach. Every month they meet, every 2, 3, 5, 6, I think I meet one more times I see my wife. Reach out to the people in your local grassroots coalitions. They have the answers that you guys didn't know were in the room. The answers you want are here right now in your towns, in your communities. So I'm sorry to cut you off and go right back to you, but please, go to these meetings. See what you can do to help. Find out what little tiny amount of effort is put in to can save one life down the road. It can simply be, I know Martin Cavalio assault. He helps out with prevention. He helps out with rehabilitation. Here's his number. That 5-second conversation can lead to rehabilitation. So I don't want to be mean, but the responsibility of finding this information is not given to them alone to give to you. It is your responsibility to find them. It is impossible for one person to reach every single person in the community. Completely impossible. Now, it's your responsibility to find them. And I guarantee when you do, they're going to help you. But you cannot sit here and say, I don't know where it is, if you never tried to look, because they're not that hard to find. I'm not saying it's enough. We need much, so much more. But the very little we do have here, use it. They will try to help.
Thank you, Sergeant. I think we all here, obviously, we don't have all the answers, and we are here to listen. We are here to learn. We are here to question, and we are here to advocate and obviously prevent more deaths from happening. So those that are not aware will have an opportunity to learn a great deal. Was there anyone else?
Yes, I did want to finish saying something. Did you want to
I just wanted to add something to what he said. We've got Hudson Valley Community Service in the back. We have business cards. You know, you can come get some information. We're going to be doing Narcan training after this, so if anybody's interested, you can come right back there and speak to us.
So one of the things I wanted to say, the reason why I brought up syringe exchanges is because oftentimes people get freaked out by the idea of like, why would you give someone that you don't want to be using drugs access to a syringe so that they can use drugs? Doesn't that condone it? Doesn't that like help them use drugs, but we don't want them to be on drugs? Here's the thing. You got to love people past the point of your comfort. If someone is struggling with addiction, do you want them to also catch a bloodborne illness? No, you want them to beat the addiction. So how do we connect people to the amount of resources that they need? When I talked about multiple pathways to recovery, you don't know what's going to be the thing that clicks for someone, or who's going to be the person that gets someone to see things differently. So when you go to a syringe exchange, and you know that the people that you're working with are giving you a syringe, asking you how your day was, giving you a snack and water, talking to you about what your day is, connecting you to primary care services. You know, you're using a syringe right now, but then 2 seconds later you could be done, and then you're like, I want to talk to someone about not using anymore. And you automatically get connected to a person right there. There is something that we have to talk about, which is not just about getting people to stop using. It's about getting people to love themselves. And what does that look like? How do we give people the resources to make smarter decisions for themselves that centers their health? And part of that is also in the way that we talk about people. When I work with organizations like Vocal New York, that also works with organizations like the Peer Network of New York, these are people that have lived everything that we are scared of. They're positive, they have Hep C, they're homeless, they're disabled, they're using drugs. And these people make the smart choices of being connected to a harm reduction agency every single day. They come in, they exchange their syringes, they talk to a counselor, they use their medication for Hep C, they do their HIV counseling, they figure out, they go to Albany and like knock on the door of the assembly member and ask him to pass some bill that will get them more resources. How do we get to the point where it's less about if someone is using drugs and more about saving people's lives? More about letting people live in their dignity. And that comes from the way that we talk about people. The stigma is killing people. No one wants to talk about what they're struggling with because they're so worried about the words that people will put on them. When you talk about, not using for 3 years and you say, I've been clean. One of my colleagues, Elizabeth Owens, will say, I was never dirty. Never dirty. And what does that mean, to stop calling people dirty? What does it mean to say someone uses drugs as opposed to calling them an addict or a junkie or a crackhead or a basehead? Power in the way that we build our language around these things. Addiction for some people is really, really hard. And there are so many things that are hard in everyone's lives. I know that I want to be a certain weight. Yet, before this conversation, I definitely ate a small Domino's pizza. And it wasn't vegetarian. Right? So it is, people are struggling with real things. And how do we change the way that we think and we talk about people? People aren't dirty. They're struggling. People aren't addicts. They're people that use drugs. Harm reduction, the idea that meeting people where they're at and not leaving them there is not being soft. It's being strong. Strong enough to put your uncomfortableness aside and centering the person that is in front of you. Yes, sure, there are people here that know the resources, and yes, part of your responsibility is to meet those people. But some of the thing is, you yourself can save a life. You can walk out of here, know how to use Narcan, and have a Narcan on your bag and use it everywhere. You can Google and find out where the medication-assisted treatment is. And if you don't have methadone in your community, you need to hold all your elected officials accountable for why the doctors in your town are not willing to end this epidemic like you are.
I know.
Because there are physicians that don't want to deal with this problem, that feel like they don't want that clientele. But here's the thing. The clientele is me. It's you. It's your sister. It's your mother. It's your brother. We're all in this together. You can't charge me all that money for health insurance and not deal with the illness in the community. All right? So if we're having a conversation about ending the overdose crisis, then we're having a conversation not only about investing in the medications, Narcan, medication-assisted treatment, access to health care. We're also talking about pushing the envelope and having conversations about innovative interventions like supervised injection facilities, like heroin-assisted treatment, figuring out what is the resources that you need in this town. Is there only one syringe exchange? Is there a mobile methadone clinic? Are there different, where is the list of physicians that do addiction medicine? And then lastly, how do we get to a place where people feel like they can ask for help? And that families who are also struggling with people that are using have places to go to talk about the stigma and find resources. Those are our 3 points. Invest in medications, push for innovative solutions, and end stigma. You can all do this. You don't need anyone to hold your hand. You have the information yourself to figure out how to end this crisis. We can do it together. And so when the assembly member says, not one more, I'm gonna say it, and you're gonna say it like you really freaking mean it. Not one more.
Not one more.
You can do that again. Not one more.
Not one more.
I'm not actually taking you seriously. Not one more.
Not one more.
Thank you.
Okay, thank you very much, appreciate it. And yes, indeed, we have to have a sincere conversation about things, and it's the only way to address this very terrible issue. But is there anyone else on the panel that needed to make any comments before I open it to the audience?
I have one more comment.
Okay, please.
Hi, my name is Vincent Trunzo, and I am a methadone maintenance counselor.
Very good.
And I am so shocked that none of you here know that there's a methadone clinic here in the city of Newburgh. I thought everybody knew. And there's over 100 people here. When a person comes to me who is addicted to an opiate, they don't know where to turn. They want their life as it was before, when they were working, when they had a family. After 6 months, when they're stabilized on their methadone, you know what they look like? Is this better?
Yes.
Great. Do you know what they look like after 6 months? They look like you, like me, and like you, and like you. It actually saves lives. People think they're trading an opiate for another drug, and you're really not. Methadone is actually a miracle drug. It blocks opiates. That's what it does, which means you can't use it after, or feel the effects. Millions of people around the world are using it. If there are any monies that the state of New York is going to give for the 5-point governor's plan, it would be for medically assisted treatment programs. We have over 400 in our program with a waiting list of over 100 more. That is amazing. And we're the only ones in Orange County. There is about 6 of us, different programs, around the Hudson Valley. And they all have waiting lists. Not only do we have to have money for that, but we also need money for education. Right now, I am educating you that there's a methadone clinic here in the city of Newburgh ready to help, ready to give people back their lives. They come to me broken, and they stay and then leave, going back to their jobs, their families, their 2-week vacations. It gives their life back. But they're just like me and you. They've lost their way. They have no idea what to do until they come to us. So that's where monies should go to. That should be the future. First being education, and then the medically assisted treatment programs, and then prevention. So important. Thank you.
Thank you. Yes, please.
I just wanted to add something. You know, Dr. Hart, you were talking about being in Sing Sing, and that was actually where my son was hoping to work in Sing Sing, because he had this conversation with me once where he was talking about the man, and you know, he was going to beat the man and all this stuff. And I looked at him, I was like, darling, you are the man. You're white, you're heterosexual, and you're a male. You're the man. So there he was in this world where he was the man, and he went to a very upper-class Catholic college. We're, you know, decidedly middle class and Jewish and lesbians, raising him. So there he went to this college with students whose parents, like their names were on the building. You know, like we're in the Larkin Center, like their family name was on the building. So they had a lot of money. And when I went back and spoke to the president of that college after Zane died, he sort of looked at me, you know, he's a friar, so he was concerned about my spiritual wellness, which I appreciated, and I mean that sincerely. He was very sweet about it. But I really wanted him to look at this issue in his campus, and he was not interested in looking at that issue because it really was just an unfortunate event that happened to Zane. And I don't believe that. I don't believe it was an unfortunate event. It was a tragedy. It was an earth-shattering, tsunamic tragedy, because he won't be in Sing Sing helping the guys that he thought he was going to be working with. He won't be having children. He won't be doing those things. So that's a tsunami kind of problem. And there's people in this audience, I see pictures on their shirts, I know are from their children that they have lost to fentanyl and to heroin. So when we talk about outreach, I agree with you 100%, and I think the multifaceted approach is so necessary, because my son never, actually we argued about the fact that he's, Mama, I'm not an addict, I'll never be an addict, but he was a drug user. You know, he was a drug user in his definition, and still I feel mixed up about the whole issue myself personally, but he certainly identified as a drug user. And so many ifs, right? But that issue in itself, to reach out to not just one area of our culture, but all the areas of our culture, because it crosses all barriers. So thank you for bringing that up.
Well, people, thank you very much, panelists, for this informative information that you have provided for all of us. And I want you to know that in this year's budget, we will be fighting to put additional money to go towards treatment and awareness and education, and OASIS and other organizations that are doing great work in trying to prevent people from dying. So at this point, I would like to open up the discussion to the audience with any questions you may have. Do I see any hands up? Just raise your hand, and someone please bring a mic. First of all, we have a young lady over here. I'd be happy to give you the mic.
Sir, hold on to because the panelists are going to answer.
Okay, well.
Good afternoon, and I thank everyone for being here, and I thank you for also hosting this on a Saturday, because you can see the people who are here really want to be here, and the answers that we've gotten from some of the people who are tasked with helping the community are not here, who've said they're here to help us. They're not here today to contribute to the conversation, so I think their absence should be noted. I'm in the process of developing a nonprofit for medical cannabis education in the area, and I'd like to ask some of the members of the panel, particularly Dr. Hart and Kassandra, about the benefits of medical cannabis as a first line of defense for treating chronic pain and also as an exit drug. I know that it's not a treatment for everybody, but I think it's a tool that should be in the toolkit for treating people with addiction and dependency on opiates to stop them from progressing their illness. So I would really like to hear what you have to say about that and how we can get that into the legislation and adding that as a qualifier to get into the program for medical cannabis conditions. Thank you very much.
If I may, as you know, last year, the New York State approved medical marijuana, although there's a lot of restrictions, by the way. But I think the foot is in the door. In fact, this year, we're beginning to have a conversation about recreational marijuana. And that's because nearby states, such as Massachusetts as well as New Jersey, are actually looking to legalize marijuana. So I think will be to our benefit, especially in these very difficult economic times, to look at this issue. So the governor has put in a commission together to look into legalizing recreational marijuana. So please.
Laura?
Sorry.
So thank you for bringing this up. I think the medical cannabis program in New York is very restrictive. It's really exciting to hear that this is something that you're putting together to bring to this area, because one of the reasons that the medical cannabis program has been struggling is because there's no geographic diversity in where the programs are. There is a growing body of research that is showing that places that have legal access to cannabis have lower rates of overdose deaths. In places that have legal cannabis, the overdose rates have gone down approximately 25%. And there are doctors in New York State that are studying it, Dr. Julia Arnstein, Dr. Marcus, I can't say his last name, it starts with a B and it ends in an R. It's like Bakashramara, something like that. Yes, at Montefiore, yes, the Montefiore doctors. So there is a lot of conversation for people talking about how they don't want to use opioids. They rather use medical cannabis as a way to manage their pain. And at Drug Policy Alliance, we agree with that. We think people should have access to whatever medication that they think would help them deal with their pain, as long as they're also given information about that drug so they can be knowledgeable drug users. So I think medical cannabis, as you said, has been shown to be very effective in managing certain kinds of pain, especially chronic pain. And it's also been shown that having a legal marijuana regulatory system in that state has been shown to have a relationship to lower overdose rates.
Dr. Hart?
I just want to echo Kassandra's remarks, and thank you for raising this issue. I just want to also just caution that there is not a need or for you to demonstrate that we have this causal relationship between the availability of medical cannabis and decreased overdose deaths, because I think that relationship, that's a correlation, And I don't think there's a causal connection, frankly. But what is clear, there's growing evidence that cannabis can be used effectively for a variety of medical conditions. And clearly, when people are going through opioid withdrawal, I mean, I have been through opioid withdrawal and those sorts of things, some people may benefit from cannabis. And when we think about the headache, we have ibuprofen, we have acetaminophen, we have aspirin, and so, as you point out, maybe cannabis could be used as one of those tools in the physician's toolbox.
If I can just make one comment also as well, and I don't want to put a damper on any of this, but one of the reasons why we approach this from a policy standpoint is because of the schizophrenic nature of federal and state law. And we know now, especially with the Attorney General's recent pronouncements about marijuana and the states that have legalized it, that all of these things are precarious. And we need to be able to understand that in order to really get an effective law and get people into being able to market it and do whatever needs to be done, whether it's medical or recreational, that there has to be some kind of assurance on a federal level that it's not going to be treated as a Schedule I drug.
You're right, and I think even the President of the United States is actually pro marijuana.
Well, that you are the only person in the room that know what the president thinks.
You're right. I do not. I know his ignorance. I realize that, but he has made statements, and I don't know if we can hold him to it. Okay. Are there? Yes. No, actually, go ahead.
Okay, so what I'm hearing is that you're preventing deaths, which is fabulous. I lost a nephew in July to a heroin overdose with fentanyl in it. And I'm all for that because I don't want to lose another one either. However, I don't hear anything about working on healing the addictions and working on getting people into rehab and actually getting them better and getting to the root cause of the addiction and why they're using the drugs in the first place, which to me is just as important as preventing these deaths. You have been to multiple rehabs, and I'd like to hear what you have to say, as well as other panel members that choose to address this. I work in rehab for men as a volunteer. I've been there for a long time, and I see these gentlemen working through their rehab programs. And just a few weeks ago on Christmas Day, my son was suicidal as a result of drugs, and spent a week in a psychiatric unit and is now in rehab. And the difference is actually incredible, and I thank God for that. But I'd like to hear what you all have to say on that.
All right, so with the agency I work for, we actually have another program called Project Outreach, and that helps people get into detoxes, methadone program, Suboxone, inpatient, outpatient, whatever they think that they need. For myself, I've been to many rehabs, many detoxes. I've been in and out of jail. The last program that I had went through was I went through a place called Transitional Housing for 2.5 months. I went through a place called St. Joe's up in Adirondack, Saranac Lake for 90 days. And then after that, I went through a halfway house and an intensive outpatient called ITAP. And I was also in a diversion court. It's basically like if you get a felony, you complete all these programs and you complete successfully, they drop the felony down. So, this time I went in just because, I actually got caught selling heroin. That's what I was charged with. And the reason I went in is because I didn't want to go to prison. That was I didn't care about stopping using. I just wanted to not go to prison. And, you know, being in the programs, I went to an AA meetings, and I got a sponsor, and I, was going to meetings every day, and I got a home group, and something just clicked in me. I started praying, and something just clicked in me, and I just didn't want to use anymore. And, I've been clean, almost, you don't like that word clean, but yeah. Yeah. So, I've been abstinent from drugs and alcohol for, almost 3 years now, and my life's better than ever. I have a son now, and I pay all my own bills. It's just great, and we gotta just, in my program, we don't really, we don't push recovery on people. We're just there to help them, use responsibly and, where they're at, and help them with, basically where they're at. We don't, I'll mention that we have other programs, and if they want to get clean, they come and talk to me, and we help them out. But
Thank you.
So you asked a great question, the causes of addiction you're getting at. One of the things that we all should keep in mind in the room is this is really important, and it's simple. Most of the people who use any drug, I'm talking 75%, 80%, are not addicted. They don't meet the medical definition for addiction. So if most of the people do not meet the medical definition of addiction, it tells you that it's not the substance. It tells you that there's something else about the people who are addicted. And so when we think about reasons for addiction, what we know that a substantial proportion of people who actually meet the criteria for addiction have other co-occurring illnesses, psychiatric illnesses, they have physical illnesses, they have a wide range of things. And if you treat those other illnesses, then you deal with the drug addiction. Exactly. And that's one. That's just one. But there are other things. You can think about some celebrity or somebody who has a lot of means and they are addicted. Addiction has a lot to do with responsibility skills, tempering your behavior in certain domains, which people have to be taught how to do those things. A number of people just don't have those skills. You teach people those skills, then you also that helps you to deal with the addiction. Other people, for example, may be addicted because this sort of activity, drug-taking behavior, is the best available option to them. They have no job. They live in rural places. There's nothing to do there. And so choosing the drug, any rational person would do that under those conditions. And so there's a variety of reasons why people meet criteria for addiction. And that's one of the things I tried to get at in my opening remarks. Let's take the focus off of these drugs and let's try and figure out the conditions under which people live.
Thank you. Thank you. First, I'm going to take one more question before wait 1 second. First of all, this lady's standing up over there, please. And we'll take 2 more questions before we take a 5-minute break, and then we'll come back.
Thank you, Mama Lauren. Appreciate you getting up there. My name is Lisa Bennett, and I lost my son, Jeffrey, 13 months ago. And I'm here with a lot of other moms, and if you want to meet me later, I have several pictures of people who we've lost in just the last year since I've lost my son. So there are several of them here. But as moms who experience loss from their loved ones that have substance misuse disease, we come out here and we try to advocate. I love everything that you guys are saying. I'm a scientist and I love facts, evidence-based things. Thank you, Sergeant Julio, for your evidence-based facts. The young gentleman on the end with the syringe program, my son died of a cardiac arrest from the use of cocaine. He was free from heroin because of the drug Vivitrol. So you talk about medically assisted recoveries. That is another one in the repertoire of drugs that can be useful. And there is a doctor here in Guinea Avenue that works with that program as well. But to this young gentleman over here, I'm sorry, I'm not very good at remembering names, but when my son died, he was also a donor, an organ donor, and because he used syringes, he was eligible for donating his organs. So that's because of the success of using the syringe program. We're talking about communication. Communication is key. And when we learn and we are educated, we don't use just one book We use several books to get our education. And I say that because there are so many resources here. We have this organization over here, Team Newburgh. I'm from Dutchess. We have Council for Addiction Prevention Education, CAPE. Drug Crisis in Our Backyard. We have Friends of Recovery. And as we know, this is a family disease. Friends of Recovery is looking to be the networking tissue to get you these resources. I give my number out all the time. Moms that are in crisis, call me. I don't know all the resources, so I call everybody else that I know. And we are on Facebook, and I'm advocating. But the simplest thing that we can do is, how many people have seen on television New Jersey saying their hotline? Where is our hotline? Well, we got a hotline number, but it's not advertised. Almost a year ago, I went to Ulster County, OASAS business meeting, and I said, where is the money for our commercial so we don't have to compete with New Jersey? Give us our damn commercial for our hotline number.
I'm taking notes.
Thank you. I will hold you accountable.
That's right, that's right, that's right.
Thank you very much for your efforts, and my name is Lisa Bennett. My cell is call me. I work, but call me. I will make sure I find the resources for all of you. And the Narcan program, I'm trained in Narcan. I still attend my Nar-Anon meetings. My son has passed, but I am a different voice in my Nar-Anon meeting, not only for spiritual support, but to disseminate information. We had our local CAPE group come and give the training. Within that week, the woman who was trained on it had given it to her son who was not using, but her son saved his brother 2 times in 1 week. We were able to get him into rehab. And the other thing is, I will talk about the law enforcement, and I think that Newburgh is partnering with a group called Chatham. Chatham is a police organization that when you walk in their doors, whether you have drugs on you or not, they will help you. They will find you treatment. They will find you detox. They've been very successful, but that's a huge burden. Had my son, who was in Albany at the time, known of Chatham, even if it was California, I would have driven to California nonstop to get him in a rehab the very next day. My son was not able to get to St. Joe's. He was not able. He had to wait 3 weeks. He had to wait 3 weeks. He was great for the first week, started faltering on the second week, and then he turned to cocaine. He didn't want to do heroin again, but he turned to cocaine. Communication, networking, community. Get your resources. Google just doesn't help. It's a start. But your next door neighbor, I'm sorry, they know somebody who knows somebody who knows somebody. Thank you.
If I could, just one point I'd like to make. The police involvement in local and harm reduction and other issues that deal with trying, as you mentioned, to work with organizations, of course, on an individual basis is great, and I think that we can all support those kinds of things. But we have to understand it's very piecemeal. It's up to an individual chief or sheriff or somebody else to be able to make that, which means that, and you talked about accountability, that is exactly what we're talking about, because the accountability also has to get to the police department. It also has to go through the mayor's office, through the commissioner's office, whoever it is that's in charge there, to put the pressure in every community, because we don't have a state law or a federal law which helps us deal with this problem. Okay, it's piecemeal, and it's not going to change until that kind of pressure is put on us. Now, I think that, you know, we're in the right direction. It's the idea of police officers, you know, helping in these situations was totally foreign when I was in the police department. All we were interested in, it was numbers and arrests. Some of that has changed even in the less progressive departments. But the bottom line, those changes are not going to take place until that pressure is put on them to say, no, you're here to help us. You're not here just to arrest us.
I just want to thank you, Linda, for your tenacity and your advocacy, and we've met in Albany, and your son's picture is on my desk. I appreciate all that you do and your willingness to help in the community, no matter where the problem may lie, not just in Dutchess, but anywhere. So thank you for being here today. I appreciate it. I think there was a question. Dawn?
Thank you to everybody for being here. First, Dr. Hart, I want to thank you. I knew Philip Seymour Hoffman personally. I went to rehab with him. So thank you for speaking about him with respect, because oftentimes I have been to panels and it has not come out so nicely. So I would like to thank you for that. I come from the prevention lens. We are charged with coming into communities and looking at the issues that actually fuel people to use substances, whether that be poverty, homelessness, domestic violence, it's all correlated. One of the issues that we're seeing, there's a lot of energy in this room about right now. We do not have this energy to propel us within our community to prevent. We know there will always be use. We understand. I'm not living in a bubble. I understand there's always going to be use. But the levels at which we are experiencing right now, we told the state years ago this was coming. They didn't listen. But they wanted to mandate us to do gambling prevention training when we said heroin is coming because you're restricting the opioids and the access to the pills. And they didn't want to hear us. So what we're doing is we're being mandated and being charged with doing things that aren't necessarily directing the problem. And then when we step forward and say, hey, wait a minute, you're not listening. You're not in this community. You're in your tower over here. And I'm not talking about you, Assemblyman Skartados, but the powers that be within this field are in their tower trying to dictate to us, not listening to us about our individual community conditions. This is a continuing problem, and it's fueling what we're seeing here today. We're not getting the funds that we need to do this work on the street level, to be on the street more, to reach out more to people, and it is continuing. And more people are losing their loved ones. My children have lost their father, 2 years court drug diversion because of heroin use, couldn't stay clean, got charged with the original. He's gone 3 to 7 years now, gone. And I'm sure the color of his skin probably had something to do with that as well. I know you know. So I think we really need to start having some real conversation about what is going on in these communities. Why do we wait till we're on the levels that we're at when we're here? We're here, we're in the streets, we're in people's faces, we're asking people to come out with us, we're asking our neighbors to educate one another. As Sergeant Fernandez said, you know, it is responsibility of others, it's our responsibility we're out there, we're out there. But unfortunately, the resources keep getting pulled and pulled. They'll get $2 million for treatment, and I'm not saying that it's not needed, and then they'll give us $100,000 for prevention. Go ahead and fight over that money, by the way. You can all fight over it, and then we'll choose who's going to get it. I have our partner back here from ADAC, the Alcohol and Drug Abuse Council. They have people going into the ERs to help people on access. They're funding 2 people for 3 counties worth of hospitals. That's ridiculous. How are they going to do their work? It's insane to me. But yet we're so quick to want to jump when there's a problem. Oh, we have this epidemic, and oh, this is all going on. We've seen this coming. You know, this is not new, as you've all stated. We've been here before. Cocaine is on the rise. No one's listening to us. It's all in the streets. Cocaine is coming back, and our African-American male counterparts are dying at the same rates of our white male counterparts with heroin. And nobody's talking about it. This is a problem. So this is why it was so important to have this data that we're getting real time at the hospital, because in the world of prevention, we're getting data that's 2 to 3 years old. How do you prevent something that's already happened? We can't look into the future. The best we can get is real-time data to try to make our decisions. So I just really wanted, it wasn't necessarily a question, it was really just to put that out there that we have to start changing our thinking on multiple levels, and we need this type of energy in the streets with us to deal with the issues that continues to fuel this and continues to hold our separate communities down for whatever those communities look like. Thank you.
So that was amazing. And the thing that I would say is, like, the energy that you just brought is the energy that was present in 1988 in Frankfurt, Germany, where there were open air drug markets, and a police commissioner actually was like, this is ridiculous. Like, we already know what's happening, and as a community, we need to figure out what is going to work for us. Because too often, the people that are in the ivory tower in Albany on the 2nd floor, the governor, he's literally playing, oh God, this is recorded. He's literally playing, you ever see that thing where there's a ball and there's 3 cups, and they keep going like that, and you gotta find, That's exactly what's happening to agencies. You got to keep picking the cup, but the cup that you pick never has the money in it. It's the same $2 million that's been floating around for the last 5 million years that they keep pushing out in the press releases. But if I ask any agency if they've gotten money, it's not the money that they needed, or they don't know what the money they're talking about that they said that they got. And so what would it look like for your area to come together and say, what is our drug plan? Not what each elected official says, but what is your drug plan? What is going to work for you? What is based on the resources that you need? What is the actual needs assessment? So it's amazing that there's a methadone clinic, but there needs to be more than one methadone clinic, right? And so, like, it's okay that there's one treatment facility, but there probably needs to be more of that. There's so many coalitions, but as you said back there, where the frick is your commercials? But why wait for it from the state? Why aren't your local radio stations saying what the hotlines are over and over again? I'm from New York City. I don't drive, so I don't really listen to the car radio, but I realize that I can't really be walking around here, so that means you guys are in the car a lot. And instead of listening to your CD, why aren't your local DJs talking about this over and over again? Where is the opioid hotline conversation that happens 6 to 7 on your weekly commute, once a week, where you can have conversations and talk about the different resources, and the coalitions can talk about the work that they're trying to do? So what would it look like, right, if we had a conversation where we decided that Dutchess County and Ulster and Orange would have a conversation that's like, this is what our drug plan is going to be for this community. And then this is what we're going to tell Albany that we need. And then there are organizations like Vocal New York, like Drug Policy Alliance, that are willing to bring the noise and bring the funk with you, right? That's what we did. Nobody even knew what Ithaca, New York was, right? Until they had the mayor that was out there talking about, I want a supervised injection facility. And literally, CNN, everybody flew over there. Do you think that happened? That's because that town said, Kassandra, we can't do this drug thing anymore. This is what our plan is. We're gonna come up with 25 recommendations, and we're gonna do that. Ithaca had no detox. Do you know what they have now? A detox. Do you know what they're about to have? 2 detoxes. And the state didn't give them money. They figured it out themselves. So if that's what you want to do, then we're willing to do that with you.
Great. Well, I think we get into the cracks of the problem, and that is, don't expect politicians to solve the issues, that we have to deal with this as a community, coming together to address the issue, and then approach the politicians. By the way, I believe in this year's budget, we are putting $175 million, and I want you to know that for the last couple of years, I brought money to CAPE, which hired 2 people that are out there in the community and going everywhere, trying to identify the problem, trying to address the problem. So every year, I always fight for funding, but it's not enough. We have to address this issue as a community, and thank you for pointing that out. Yes, us politicians.
Elected officials, they don't lead the parade, they follow it.
That is correct.
You guys have to create your own parade.
That is correct.
I just want to add one thing to this real quick, sir, if you don't mind.
Go ahead,
I
Sergeant.
apologize. Can you guys hear me with this one? Yes? No? Yes? Great. All right. First, I know data is not the most exciting issue to talk about. It's not. It's relatively kind of boring. Numbers are really kind of boring. But they give focus, and they give drive to certain situations like this. Now, the data we've collected, we're not funded to get. Throwing that out there. We haven't got 1 cent from anyone to collect our data. We hit the streets, we ask questions, we developed our own systems, and we gather our own data collection systems. That being said, the answer to the question of stopping the next epidemic is collecting the right information today and crossing over county lines to collect that information. So we started getting data retrieved from about 4 or 5 hospitals without any funding, because the hospitals themselves want to start connecting with each other and figuring out the responses and reasonable reactions to the situation. This mic is really weird. So I see a lot of fire and passion in the room, and that's amazing, and I love it. And I see a lot of people energized to do something right, but without giving the correct tools and know where to put your efforts, you're going to be spinning your wheels for a long time. Right now, Poughkeepsie is much worse off by the numbers than Newburgh. Everyone thinks Newburgh first and Poughkeepsie. No, it's your efforts should be put into Poughkeepsie. That's where the epidemic is spiking now in comparison to this city. For your people going into the hospitals, we know the best times to place those personnel in the hospitals because we have the data to show which is the high hits of people entering in hospital with Narcan usage. And I know this is very boring, and I apologize, but anything that's data-driven with real points behind it needs to happen. Passion without real numbers, passion without real purpose is just passion, which is phenomenal but has no conclusion. So just keep in your minds when you guys are going through these epidemics and these horrible cases that you have to understand the situation as it is right now, current time, real-time data, or else you'll always be chasing the effects of the situation instead of getting in front of what's causing the situation in the first place. So to your point about finances, you can get a lot done just by knocking on a door and saying, can you help, and how can we do this together? So that's all I'm gonna really say about that.
Thank you. I know there are a lot of other questions. Can I just take a 5-minute break, bathroom break, please? A 5-minute, quick 5-minute break, and then we'll come back, continue the conversation. Thank you very much.
Thank you for the break.
Absolutely.
Thank you for the break.
You're welcome. Now, I know there are a lot more questions to be had, and please raise your hands and we can continue the conversation. The lady at the back of me, somebody bring a mic. Steve?
Thank you. Is it working?
It's on.
It's on? Okay. My name is Sharon Herring. My husband, Jim Herring, we lost our grandson to an overdose in August of 2017, and my sympathies to you. We started a foundation immediately called the Matt Herring Foundation in hopes of stopping the stigma. My husband and I have a support group that we run in Fishkill on Thursday nights because we needed to do something to help the families that are suffering from having a family member that's using drugs or addicted to drugs. My grandson did not think he was an addict. Zane did not think he was an addict, and yet they're still gone. There has to be an answer. I have a question. You run a methadone clinic, but there's 100 people on the waiting list. Does that mean there's 100 people that are actively using, hoping to get? Yes. So what happens to those people, and what happens to those families?
Unfortunately, they have to wait until they are able to enter the clinic.
In the meantime, I wanted to thank everybody for coming.
Unfortunately, they have to wait until they're able to enter the clinic. That's why part of the governor's 5-point plan should be to invest more in medically assisted treatment programs. We need more. We need bigger. It is a pandemic out there. It is tremendous of what we're facing. We are limited by OASIS on how many people we could take. We're close to capacity. We're about 100 away from capacity. And we need the approvals and the funding to be bigger. That's the reason why those individuals can't get in. And that's the same way throughout the other 6 treatment programs in the whole Hudson Valley.
That must be a very hard position for you to be in.
What was that?
That must be a very hard position for you to be in.
It is very hard because I know exactly what's going on out there. We know part of the solution. We need the state's help for the funding. We need more money. That's the bottom line.
Okay.
And we know it's coming eventually.
I hear you. We put in more money in the budget. I think all the organizations that are involved, we should get together. We'll put a plan together, a letter of ask.
And we can.
And we can, and we should, and submit it in this year's budget.
I agree.
Okay.
And just a little side note, that was the issue of single-payer health care, right? Was that people were going to die waiting on lists. So I just want to mention that. We don't have single-payer health care, right? And we're still dying on lists, so.
And I want you to know that there is something that has passed the Assembly year after year, and we are very close to a single-payer health care system for New York. We just need 2 votes in the Senate, and we get it done. And we don't have to depend on the federal government. This gentleman right in front of me.
Thank you. I wanted to thank all the panelists. It was very thought-provoking conversation, Assemblymember Skartados, and all the people that are here right now. So a lot of what Kassandra said about these 3 points about how do we deal with the opioid crisis in New York State are all legislation that we can have passed. These are things that we need our New York State government to fund. And there is a very active campaign called, you can hashtag it, hashtag Endoverdose NY. And we are doing work. We have a platform with those 3 points that are laid out very clearly that we are having actions and lobby events to uplift to the New York State government. And I need folks in all areas of New York State to be on that listserv, to be at the call to action at any moment so that we can have these things happen so that we can save lives in New York State. So I'm the statewide organizer. Even though we are based in Brooklyn, we are a statewide organization. We organize low-income people living with HIV and AIDS who have experienced mass incarceration, people living with hepatitis C, and therefore people who use drugs, people who are victims of the failed racist and classist drug war. What we experience right now in this state, in this country, is the legacy of bad laws, of treating drug users like they're not human beings. And the way that we can really do that, and I feel like it's been referenced, is we have to use the word organize. We have to build political power with the people that are directly impacted by these horrific laws, by these horrific situations and health outcomes. And if you want to be a part of that change, if you want to help us build this with Vocal New York, with Drug Policy Alliance, with Harm Reduction Coalition, please, I will pass around this sign-in sheet. You can talk to me, to Angie Woody in the back over there, who is principal in organizing this event, and we will follow up with you.
And yeah, go ahead, give him a round of applause, sure. And as you know, one of my colleagues, Linda Rosenthal, has introduced legislation about safe spaces in New York State, so I'm a co-sponsor of that bill. The lady in the front.
Thank you. My name is Lisa Marie Martinez. I'd just like to say my friend's name because she died alone and lonely. Her name's Melissa Merritt. I'm assuming that this year when the CDC publishes its yearly record, or I don't know how often they publish their findings publicly, they're not going to be able to use the words such as scientific-based or evidence-based information. And also, something that you had said with the hysteria about epidemics fueled, I'm sorry, I'm really nervous, with the, that's not usually like me if you knew me, actually. Anytime I can be in front of a microphone, I'm quite happy. But when you said this hysteria about the overdose or opioid epidemic is used to fuel the criminalization of bodies of color, knowing that those two things are true, and with all of the work that we're having to do with resisting against backlash by those in power, what can we do for those of us who aren't opioid users or drug users or are users of drugs in a way that isn't harmful to our daily function? To talk to our children. I talk to my son, he's 6, on a daily basis about crossing the street safely. I talk to my son on a daily basis about no means no. How do we then talk to our children in a way that is responsible and informative so that their first interaction about talking about drugs isn't in a DARE program or isn't in a way that is destructive to bodies that are already marginalized? Thank you.
Thank you. Thank you, Lisa, for your question. One of the things that happens in the United States when it comes to talking about drugs is that we throw the children's issue out to shut the conversation down. We don't want our children using these drugs. I have children. I have 4 children now. Every year I write a book, I discover I have a new child. I have 4 children. And so I've had this conversation with my kids. When I think about the drug conversation, think about this. We have a conversation about alcohol. We have conversations about caffeine. We have conversations about tobacco. We think about this fact. Alcohol, it's probably the most dangerous of these drugs that we're talking about. I mean, alcohol is chemically ideally suited to get into the brain by drinking it orally really fast. So there's like no barrier. There's a blood-brain barrier for most things, but not for alcohol. It's in the brain like that. And if you are a chronic alcohol drinker and you've been using it for a while and you have to go through withdrawal, you can actually die from alcohol withdrawal. You can't die from heroin withdrawal, you can't die from opioid withdrawal, but you can die from alcohol withdrawal. Now, we're comfortable having the conversation about alcohol with our kids, but we're not comfortable having a conversation about drugs. In part because people are ignorant, and if they're ignorant, we avoid the conversation. So we need to make sure that the parents are educated. That's why I start out to say things like why people would use opioids. It's a rational choice when you understand what opioids do. The question becomes, how do we make the activity safer? And that's where we start our education with our kids. I know you may not use the drug, but here's why people might use it. Here's some signs that something might happen. Here's something that's important to tell your friends. If they're using opioids, don't combine it with alcohol. Don't combine it with their Xanax. Don't combine it with an antihistamine if they have a cold or something of those nature. Simple conversations like that helps us.
Thank you.
Or, children are different than adults, obviously. Don't lecture your children. Maybe at school, have someone who is recovering from addiction, who would tell them about that. As a parent, sit down with your child, discuss about it. Maybe on TV there's a movie in which they're using it. Well, he's going to ask about that. Well, you explain to him. I have an 18-year-old. So socially iPad and iPhone savvy, they actually look for this information. They self-educate, at least mine does, and the group they're with. So that's how I would approach it.
I guess I need more to change the culture around actually using, right? So if we're talking about, I guess what I mean is changing the culture about how we're talking about actually using. You know, we can't rely on having conversations. I'm 31. I'm not that old. We can't, and my parents still should probably talk to me more about drugs and sex. So I guess my point is, how do we then talk? How do we bring these to conversation? I mean, I talk to my son about why I protest. I talk to my son about why I'm not at the Women's March today and why I'm here instead. My son is 6. We have to have these conversations about oppression and oppression of people of color and oppression of those who don't have the same abilities as us in many different ways. And so this just seems like a way that we should be having the conversation that I never thought of. My family has been touched by this, or our friends' families have been, all of us here obviously have been. And so I guess I'm taking it not just talking about prevention and not talking about the normalization of usage, but how we create a culture for our children. So I guess not just let's talk to our kids about drugs, but I was looking for like specific words.
I'm sorry, I get it now. So we
we talk to our children about their anatomy. What do we say to
No.
young children?
I think I understand a little better. So we have to let our children understand that our drug laws and our drug policies are designed to subjugate people that we don't like. I mean, that's the honest conversation. When we understand the fact that in this country today, we are concerned about opioids, and you all have seen the articles, the TV programs that say, oh, we're now concerned because white people are being affected. But I think that's disingenuous, actually, and that's too simple, because opioids, it was always white folks. That was always the case. So that's kind of disingenuous. That's who we've been. But the thing that's important for your kids to understand, and with that regard, check this out. Most of the people who use opioids, we all know, are white in this country. And when you buy your drugs illegally, you buy your drugs from someone of your own race. That's what the evidence shows. 80% of the people who are arrested for opioids in this country at the federal level today are black and brown people. And so there are I've written on this, a number of people have written on this, so there are all kinds of numbers that you can show your kid the hypocrisy in which we engage in this country when it comes to drugs. My brother here kind of started off by saying this. As a police officer, he saw this sort of thing. And so if you want to be completely honest, that's part of it. But also being completely honest, that's why I start with my conversations by saying, I'm a drug user. Today, I've been through these sorts of things, withdrawal and those sorts of things. Well, I'm not white, but if I was white, I would be the typical drug user. Someone who is responsible, someone who's doing these sorts of things. In these conversations, and I get it, they need to focus on people who are having problems. But we can't lose sight of the fact that the overwhelming majority of people are not having problems that are related. And they're not in part because some of those people are in communities where they're sharing information to keep people safe, while the rest of us are engaged in this dishonest dialogue about how awful these things are, and we're not sharing. Don't do that, do this.
Thank you.
Well, if we're not honest with ourselves, then we'll never go anywhere, right?
I just want to.
Wow, thank you. Absolutely. There's a young lady in the back.
I just have
Sorry.
one person over here.
Thank you very much. Can you hear me? Bear with me. You know, I heard what you just said in your question, okay? And the first thing that came to my mind is I'm older than you, obviously. I'm an old guy. But I have 3 grandchildren. And I have a history of use in my family, all right? And one of the things that's stark in my head, I'm probably not the sharpest knife in the drawer, but one of the things that's always been stark to me is that I guess my generation, maybe some of those guys in my age, I know that guy isn't, but maybe some of the other guys in my age, have been part of a culture that reacts to a crisis. And because we react to a crisis, it tempers everything you're talking about. It tempers how we talk to children. Because whether we want to recognize it or not, if we're too busy chasing the crisis, the horse kind of left the barn. And that scares me for my grandchildren. It scares me for 3 children that I love more than me, all right? I had a conversation the other day with 2 people from Governor Cuomo's office, and we're talking about statistics. And they were asking me my opinion about the opiate crisis. And I said it can't be that simple because of the collateral issues that fuel this crisis, which Dawn was talking about before. And these collateral issues, if left unchecked, they're just going to spur another, crisis. And then I see that child there, and I just want to kiss that child. But I want to give that kid a chance. And I want righteous information and proper development to be part of that child's life. So the question is that, to answer your question, I know I'm going on, but to answer your question maybe, is part of what we need to do, part of what you need to do, is make folks accountable. Part of what you need to do is make school systems accountable. How come they will teach this but not that? And we're not talking about telling a 2-year-old, don't shoot dope. We're talking about a discussion with a 2-year-old that recognizes what is safe and what isn't, who to go to, what's nutritious, what are good habits, and begin that dialogue at a very, very young age, all right? So it goes well before this panel or me, all right? So I had to tell you that, because the reality of it is if we keep reacting to crisis, we keep fueling a culture and an economy of pain. Because pain, I work for Catholic Charities. We do a lot of wonderful things. These guys do a lot of wonderful things. But do not kid yourself. If there was not pain, I'm out of work.
That's right. Yep, right on.
All right? And so part of my point to this, too, when we talk about prevention, and as a grandfather, my kids, my grandkids, I push the hot cup of coffee away from the edge of the table because I want to prevent my child or my grandchildren from getting burned because I love them. But somewhere along the line, culturally, we say, you're old enough where we don't have to push that away from the edge of the table. Nothing can be further from the truth. So now goes full circle to what we were talking about before. I applaud you for your efforts for funding. I applaud you for your efforts. But the issue is not looking for funding. The issue is the disparity between what we're going to do for that child, prevention-wise, and treating. When I was speaking to people the other day from Cuomo's office, and they were asking me, what do you mean disparity? I said to them, if you have children, would you rather have $1 million put in your bank account for when they have a substance abuse disorder? Or would you rather have $500,000 put in the bank account and another $500 be used to prevent them from having a substance abuse disorder? All right? And that is the disparity that you guys, everybody in this room, I've been a community organizer for 40 years, I'm not that old. But everybody in this room has a chip in that game. And if you got a chip in the game, you can win. And my heart goes out to anybody who suffered loss. But to sit here and talk about funding but not address the disparity between the funding to prevent the child from being sick and the funding that goes into treating that child once they are sick, to me is obscene. And I would beg you to consider that. Thank you very much.
Well, I just want you to know that my doors are always open. My staff is ready and willing and able to sit down and have the conversation that we are having today and see what we can do. Listen, the only thing that can happen is that, we can keep on pounding the doors until something gets done. I understand. I'm willing to have the conversation here and elsewhere. My doors are always open. The staff are ready and willing and able. So let's get together as organizers, as community leaders, as people in pain. I'm willing to work with you and advocate on your behalf in Albany. Thank you.
Hello, my name is Faye Allen. I'm a disabled Army veteran. I'm here by way of Holy Trinity Church of Unity. Thank you for your service over there, Sergeant. I'm here to address excuse me, I dropped the paper. Is Dr. Carhart and Lauren Mandel, and of course Sergeant Julio Fernandez. Anytime I get sick and I go into the hospital, I'm epileptic, they treat me as if I'm having a withdrawal with my seizures. And I have no idea why. I'm not on any narcotics. I'm not having any withdrawals from any type of withdrawals from any opioids. So this is what I want to address. I'm coming from another aspect. I'm not any type of drugs. So I don't understand why I'm treated like this when I go to any type of hospital facility. So this is one way that the hospitals and doctors are wasting their times. And they're wasting their times, they're wasting their tactics, they're wasting their medicals, they're wasting all type of tests on me when I'm clearly diagnosed as epileptic and I'm a veteran. And it's in my records.
I'm a veteran as well.
Congratulations. Thank
Yeah,
you
I
for
did
the
4
service.
years in the military as well. In fact, I was a cop in the military.
Yeah, so sir, you know, I cannot take any type of narcotics if I'm an epileptic. It lowers my seizure threshold.
So I'm just wondering, when you asked that question, so like you could have withdrawal, for example, from even the anti-epileptic medication. So I don't know if that's the kind of withdrawal that they're thinking about, or...
But I'm not on narcotics, I'm not on any opioids, I'm not on anything.
No, you can have withdrawal from anti-seizure medications, antidepressants, you can have withdrawal from a wide range of medications, you can have withdrawal.
But they treat me like I'm on drugs when I go in there. Like, when I'm coming out of my seizure, they're like, what did you take? Are you on drugs? They want to do urine. They want to do blood work. They're talking to me like I'm a junkie. But it's in my records.
No, they're talking to you like you're a black American.
Yeah, exactly. That's
Stigma. It's a stigma.
Right.
It's a stigma.
I don't mean to interrupt. I don't mean to interrupt you, but I just want to tell you something, because when I was a police officer, we had a word for people that we didn't like, okay? And I'm trying to be as politically correct as possible. We call them skells, okay? And what happens is that when you get a skell, you assume certain things about them. The medical profession is no different than police officers when it comes to this. You develop certain opinions about people based on their race, their ethnicity, their background, their class. Those are done as defense mechanisms first, so that you can deal with that situation, but it becomes pervasive in terms of how you deal with them. Now, I don't know your experience, but I can only imagine that seeing you on the street going through a seizure, whatever the story is, even if it says you're carrying all your identification that says epileptic and everything else that on it, I guarantee you that if you were on the street that I was patrolling, you'd be treated like a skell.
And so part of you're right, it's wrong. But even if you did use drugs, them treating you without respect is still wrong. So I think part of the thing that we talked, so part of the thing that I had talked to someone else about was that I don't care if you've been using drugs for 35 years. If you walk into the hospital and you need medical assistance, you need to be treated as the same way as someone else that hasn't been using drugs for 35 minutes.
On any type of drugs.
No, I'm not.
None.
No, I'm not saying you are. What I'm saying is that regardless if they thought you were using drugs or not, there is historically documented racism against people, black people, when they enter into medical facilities. There are studies that are being published last year that showed medical students think that black patients can take more pain because of slavery. So ancestrally, we can take more pain. Yes, there are medical studies that show that in the dying moments of black patients, doctors stand at the door while someone takes their last breath, as opposed to white patients where doctors are holding their hands.
Ma'am, I know. I have a medical degree, too.
So what we're saying is that when you ask the question, what I'm giving you back is because of the way you look. Race is one of the biggest reasons as to why people treat you the way that they do.
Let's see, there's a couple of more questions in the audience. There was
Can I say something too? At the risk of offending everybody, I'll say it anyway. Also, the reality is that at St. Luke's Hospital in a 12-hour shift, there's at least 10 people that come in, and this is just average, just nursing-wise, that come in that are overdosing. Whatever color or shape they are, they come in overdosing. So we're really taught to assume that anybody that comes in with a certain set of symptoms that we use Narcan, and we do ask that question. So I'm not denying racism in any way, and I recognize that actually white privilege, is one of the reasons why my son is dead. So I recognize that, but I also just want to normalize the fact that this this reality of daily overdosing that the ERs see, that they have gotten the message that it comes in all different shapes, sizes, and colors. So I just need to say that.
I'm going to jump in for one quick second because I do work very closely with St. Luke's Hospital, and I'm not negating any of the words that are said by the panel and or the audience, but I feel like this should be said, at least for the record. St. Luke's has been very instrumental in helping us try to get a hold of the data that happens in Newburgh. They also have let in peer and Gavit. They also let in peer navigators, and they work very closely with rehabilitation centers and policies within the city. They are very quick to call someone for help. They're very quick to say, we have someone here in the ER, he just overdosed, he's looking for treatment, can you come get him? And there's multiple agencies in the city of Newburgh who will leave their beds at 12, 1, 2 in the night, go to the hospital, pick them up, and try to find them resources. Now, the hospital is overburdened. I see the numbers literally every single day. And they come over my phone pretty much all hours of the night. Mentally, it is straining on an individual to see this over and over and over again, and that's not an excuse for maltreatment, ma'am. I'm saying that right now and clear. But they are doing their very best to help the people they can with the addiction problems that enter their doors. It's a monumental task, it's an uphill fight. And they've been successful in getting a good 6, 7, 8, 9, 10 people into treatment centers from their incident inside the hospital and pushing forward in this collaborative. And they're trying to work out with other hospitals to see if they can help them as well. So the task is monumental, and I really put my hands out to those who are on the board right now that deal with this every single day, and the social workers have to do this every single day, and A soldier's life's easy to those who have served. We give our orders and we follow out, and we have no mental strain. The mental strain of these professionals every single day is daunting. So my hands go out to those who are fighting this addiction and fighting this problem, because I can only imagine them, what they have to go through. But the hospital is doing, at least in their part, trying to help the situation as it comes in hand.
Thank you, Sergeant. Sir?
Hello, how you doing today? I'm a local business owner in town, and I try to do as much for the community as possible. And listening to everybody here today, I've picked up a little bit about us needing to educate ourselves, questions we should ask. I get a lot of people asking me for help with local projects like farmers markets, like different outreach for the community, because there is not enough funding. When are we, the village that raises a small child, going to get together and educate one another? I can come in and say, I'm going to employ someone that's struggling because I can give him a chance. Before that, before a month ago, I was stereotyping. I didn't want to hire an addict. I was afraid for my money, for my business, until I was forced here. I should have been here a long time ago. I should have been doing a farmer's market about this problem that we're having. So I encourage everybody that's here today is reach out to your neighbor before they're forced to come here. And reach out to, just talk about it. If it wasn't for a simple cup of tea with Alex, I wouldn't have been here, because I wouldn't have known about it, and I would be in a dark room by myself dealing with this alone. So my opportunity for everybody here is to offer, let's reach out to our neighbors and let them know that, hey, this person's a good person. Let them come to me and ask for a job. Let me put them in front of my customers and represent me and give them the opportunity, so they're not carrying the whole world and no one understands them. Let's understand them, and rather than being disappointed when they fail at bat. I mean, we're asking these kids and adults and everybody to fight the hardest fight of their life. That 9 out of 10 of them fail every time they get up, but one day they're going to hit that run. And why are we disappointed? We cheer when Derek Jeter strikes out sometimes, because we love him. But these are our kids that we have to get together and encourage them that they can step outside and can see the daylight, and let the world see them and let their beauty shine that way.
Thank you, sir. Thank you. Absolutely. Let's fight as a community. Who had their hand up? This young lady over here. I'm not sure which one was first. Do you know? Okay.
Hi. I just want to say that there's a commercial that says depression, who does it hurt? It hurts everyone.
Right.
Addiction is the same way. It hurts everyone, not just the addict, but it hurts the family. It doesn't have any boundaries. It doesn't care about how much money you have or what color you are. Addiction attacks and hurts everybody. I was married to an addict, and I will say addict because, you know, just the terminology of saying drug user makes a difference. It doesn't. Because, you know, we take drugs every day for symptoms that are wrong with all of us, whether it's diabetes, whether it's your thyroid, whatever it is. We take our medicine the way it's supposed to be. An addict will do anything it takes to get his medication, which is whatever drug they are hooked on. So my husband is an addict. My grandchildren are out in those streets, addicted to heroin. You wouldn't even notice who they are today. I can't even recognize them. I'm in those streets all the time, feeding them, the people, talking to them, being with them, helping them, doing anything that we possibly can for them, to help them, to get recovery. I have a niece that was hooked on heroin who came off of heroin herself, and I told her, I said, there was a gentleman here that said, let me quote, methadone is a miracle drug. My niece wrote me back and said, no, that's just getting you off of heroin and getting you addicted to methadone. So when do we come off of all these little crutches and start living life without something that's going to just keep them where the government society wants them to be? When do we open up recovery places? And you know what? We just went through this with my grandson, with her son, trying to get them into a recovery. Do you know weeks, months went by because we had to fight getting them to a doctor, getting them some insurance to get the door open, to get them into a place to help them. Going down there, methadone, what is your ratio? What is your percentage of a success rate to where they actually succeed and get off of it and get back into life? What is the percentage of that? Coming together as a whole, as a community, as a nation, yes, we need to do that. We need to understand. We need to find the problems within and get them the correct help that they need and start opening up facilities for them to get into. Not just give them something that they're going to use. I work in a hospital too. You give them methadone and they come in and check their blood, and guess what? They not only have the methadone, but they have a whole lot more heroin in their system with it. We need some real answers. We need some counselors, psychiatric treatment. We need a whole lot of stuff that go into this. Another pill is not always the answer. It's called recovery for a reason. You give that man that fish, he'll eat today, but you teach him to fish, he'll be able to take care of a lifetime. Teach them how to overcome this stuff and not just reach out for another crutch. Amen?
Can I say something? I just want to say something quickly. I agree with you. Methadone is not a miracle drug. There's no such thing. So when people talk about any drug in that way, that's not true. You're absolutely right. Now, my mom, she has diabetes. So she has to take her medication every day. Now, I would be a fool to say, like, what the hell are you doing? Get off of that medication. She also has hypertension. She has to take that medication every day. It saves her life. I would be a fool to tell her not to take that medication. The same is true with something like methadone for people. We will be foolish if we don't use something that could help people do better. Help people. Please hang on. I heard you. I'm glad we're having this conversation. We would be foolish if we have a medication that helps people to continue to be engaged in a society or to be better, and we don't give them that medication. Now, that doesn't mean that methadone works for everyone, because it may not. And when we think about methadone, the important thing about methadone and maintenance medications is that you have auxiliary treatment. You have a psychologist or a psychiatrist, you have a social worker, you have all of these auxiliary treatments in order to deal with drug addiction. Because drug addiction is not just some chemical imbalance. That's not it. It's this whole psychosocial thing that we need to treat. So we are foolish to throw away methadone, or we are foolish to say that someone should get off of methadone, or think of it as a crutch. We just had New Year's Eve celebrations around the country. There was a lot of champagne there, and every year. Are we saying that the champagne is a crutch? No, it helps people to celebrate better. I am a chair of a department, and I have to go to all kinds of boring-ass receptions. And there's alcohol there. And I'm glad it's there, because I have to deal with those people. It's not true. It's not true. It enhances our time. It enhances the sociability. Are you saying we should get rid of alcohol in the society? As I said, well, I don't want my mom to come off of insulin. I don't want her to come off of her hypertension.
All right.
daily basis that makes you healthy. Healthy. Your mom was getting healthy. She wasn't getting addicted to something that she had to go throw her life out about. There's a difference, and you can sit up here and say anything you want, but you know what the reality is? They're still out there in them streets addicted. There are family members that are dying every day. There are family members that have been in these programs, taking the pills that you're talking about, that is not helping. And when you go down there and you talk to them, I say, why? Why are you doing this? Because they're masking something inside of them that
what's
they
your name?
cannot face and they cannot handle.
What's your name? I
And
want to call
so
you by your name.
therefore, you know what? That's the problem.
What is your
Finding
name?
out what they need to handle
I want
and
to call
face.
you by
My
your
name
name.
is Tammy.
Can you say it again, please? I'm sorry.
Tammy.
Tammy, I feel your pain. I mean, but in this forum, I mean, maybe you and I could talk afterwards because I think I feel your pain and I completely understand. But in this kind of forum, we can't really talk. But I really want to talk to you afterwards. Okay? Please?
Can I also just say that I think what I said earlier is important, which is there are multiple pathways to recovery. There are some people that decide to use medication-assisted treatment, and they use it while they're, moderating their use, and then work with their physician to get off of methadone. And that is their choice. But someone who has decided that medication is how they're going to moderate their use and come on and stabilize their life, and they can be on methadone their whole lives and feel happy and pay taxes and take care of their kids. That's a large percentage. It's a huge percentage actually, and I can give you the fact sheet on that and we can follow up. But what I'm saying is I think it's important to recognize that there's not just one way to recovery. There are multiple. So what I'm saying is, so all I'm saying is that there are multiple pathways to recovery. Some people use medication, some people don't. And that decision is between that person and their physician.
Okay, listen, I appreciate the question, and like the doctor said, he'd be happy to talk to you later. Obviously, wraparound service will be extremely important, but there are a couple of people that have questions and they want some answers, and I would appreciate that we keep the conversation moving. Who was the next order, please?
Hi, my name is Pat Rosa, and I lost my son Christopher 10 years ago to a heroin overdose. I'm one of 10 people that I counted, and there may be more in this room, that have lost children to this epidemic. I just want to address education. I'm part of the Council on Addiction Prevention and Education. I'm on their foundation board, just as a mom. I'm also part of Friends of Recovery and the Southern Dutchess Coalition with Sargent. Education is paramount. The DARE program was effective when my son was 5, 6 years old. I don't even know is it in existence any longer? I'm not sure.
Thank God it's not.
It wasn't effective then. It's not effective now. CAPE has educators in 4 Dutchess schools, 4 out of 14. I don't know why the schools are not recognizing that this is a huge problem and our kids need to be educated early. I personally have gone with CAPE to a 4th grade class in the city of Poughkeepsie for the last 3 years. They bring fun things like Clem's Phlegm and all of these things that 4th graders would love to talk about and get disgusted with, to teach them on their level about anything from tobacco and alcohol to drug use. The questions those 8-year-olds have are, should I be in the room when my uncle smokes his bong and my mom drops her needles on the floor? Should I be afraid that I might die if I get stuck by one? These kids are smarter than we are, and we need to educate earlier. I just met with the Highland administration and superintendent of schools there. With my friend Vivian, we've come up with a documentary called Not My Child. It's 7 parents who have lost children to overdoses. And Highland has lost 14 students in one graduating class to overdoses, and they have recognized that there is a problem and that they need to educate earlier. So the new superintendent is going to mandate that every middle school and high school student attends a forum and views this video as a mandatory thing to participate in any after-school activities, sports, and that's a start. But that has to happen in every single school in our counties to make a difference with these children.
I met with Vivienne, not my child. We had a conversation, and we are looking to see how we can advance that into the school system. Are you my neighbor?
I am.
Very good.
Your goats eat my grass.
Excellent, excellent. Thank you for allowing them. Appreciate it. That's right.
Tammy, I just wanted to make sure that I got the stat for you very quickly. So just right now from the California Association of Addiction, it says detoxification and drug-free modalities, although appealing to an understandable desire for recovery without medication, produces only 5 to 10% success rate. Methadone maintenance is associated with success rates ranging from 60 to 90%.
Okay. There are a few more questions. Thank you. Appreciate that. There are a few more questions. Who had their hands up? Oh, Mayor Cassell. Thank you for being here, by the way.
First of all, I'd like to thank you, Assemblyman, for having this and all the panels.
Thank you.
I sit here and I listen, and you know, I'm probably one of the oldest people here. I come through the generation, and I think you got to be honest with people. You can't say, I never used drugs. You know, people look up to me, I'm the mayor of the city. If somebody asked me, did you ever use drugs? I would never lie to them. I'd tell them the truth. My problem is...
So you did?
Yeah, I did. I'll admit it.
Gotcha.
Believe me, I tell the truth.
Thank you.
And you know what? Was it right? I don't know. I never got addicted to anything. But I don't have an addictive...
Well, and I think that's the point, by the way.
I don't have an addictive personality. What I see is missing at this forum is how do we address people that have a genetic background of addiction, of a genetic addictive personality. Because if you're not getting addicted to drugs, you're getting addicted to alcohol, tobacco. You're getting addicted to watching QVS and spending millions of dollars on stuff you don't need. You find people have all that stuff. So my problem is, the underlying problem is a problem that people have addictive personalities, and when they do have that, how do we address that problem so they're not getting addicted to anything, and how do we help them? And that would help with drugs. And I also, and I'll be honest, I say this right now, you know, in the old days, a lot of corrupt people made a lot of money off alcohol because it was illegal. In our society, we didn't learn from that mistake. And I think if we take a step forward and learn from that, we stop the bad stuff from being on the street. It would be sold, people knows what they're going to be buying, and the money that's made can be used to solve these problems that we're talking about. And I will stand up and say, we should learn from our past. Thank you so much.
Yeah, no problem. Thank you.
Mayor, can I ask you to lead with what you finished with? Because what you finished with was spot on. I mean, the thing that we're concerned about are the adulterants and the things that are potentially killing people. So if you can lead in the future with that. And that the first point about the addictive personality, you said it wasn't here. That's right, because there's no such thing. There's no evidence. There's no science evidence, no gene. Although we like to talk about it in the public like it's real, there's no such thing. It's hard work. We have to figure out the conditions under which people live and how do we make it better? How do we figure out what's going on in those people's lives, like psychiatric illnesses and those sorts of things? That's where we should be looking. This notion of there's a magic gene or there's a gene that tells us, it doesn't exist. That's why we're not having that conversation. So in the future, please lead with, we should be legalizing these things so we can control the quality. That's where the mayor should lead.
I really believe that's the simplest thing if we look at our past history, because we went through Prohibition. We found out who made all the money, what went on with it, and this is the same thing, just a different type of product. So I think that's a simple thing to get to, and I believe we should be doing that wholeheartedly. Second of all, I'd like to talk to the gentleman in the gray shirt. People like him that speak about what he went through, talk about education, Pat DeRosa. We need to get people in the schools that lived it, did it, and talk about it so people understand it, because people relate to people that lived real life experiences. They don't relate to some politician telling them, well, you shouldn't do this or you shouldn't do that.
So why do you have such trepidation to tell us about what you lived, what you went through? I mean, that's the point. You told us that you were a drug user, but then you had all this trepidation about it. You're absolutely right. Tell people, I did it, and this is how I stayed safe. And
I did it all. I tell people.
Please, hang on. So we need to have people who do it without problems so they can show other people what worked. And then, as opposed, think about this. Think about this fact. When we teach people how to drive a car, we don't go to people who only got in accidents to teach us how to drive a car. That's ridiculous. And so we need people who do it safely and right, talking to. Not just those people who are having accidents. No disrespect to the people who are having accidents.
I'm not disrespecting him. I'm saying I applaud him for what he's doing.
Very good. By the way, I'm addicted to food, so I'm developing borderline diabetic. So, but I'm trying to control this situation, see? Were there any other questions? I know we are running out of time, and I want to be as quickly as possible because there are a couple more things that we need to do. But okay, you have a question right there, please? Jill? She's going to give you a microphone. No, I'm not calling you, Jill.
Hi, how you doing? I'm Dinette. I'm a social worker. I work for Office of Mental Health. I've been in the field for 25 years with substance abuse and working with severely mentally ill individuals in the community, many of whom lack judgment, right? Have very poor judgment skills. A lot of folks who don't think they need medication because they don't have a problem and they're fine. So to keep people alive who are using, who very often think, I don't need medication, I don't have a problem, I'm fine. That creates a situation, right? You said that you finally got it together when you went to rehab, basically because you were facing a felony. And you decided to do that instead, so there was some kind of a viable outcome for you to avoid jail. So you had a thoughtful decision and decided to do that. But how many times do the people who are using, think they have a problem or have the ability to make a clear decision to go get help on their own when they don't think they need it? And meanwhile, right, their lives and their families' lives, everybody's falling apart all around them. So in the mental health world, here in New York, right, we have something called Kendra's Law. Are you familiar with Kendra's Law?
Yes, ma'am.
Right? Assisted outpatient treatment, where basically the person who lacks judgment, who thinks they don't have an illness, who thinks they don't need medication, right? The family members can go to court and petition the court to make the determination if that person needs treatment or not. It helps. You're shaking your head back there. You know what I'm talking about, because we know the same people, right? So people who can't make that decision on their own or can't recognize that they have a problem or who won't take the medication to keep them functioning, and doing well in the community, the court system does step in. They don't go to jail, right? But the judge orders the person to treatment, and usually medication is ordered on the treatment. If the person refuses, they'll go to the emergency room to get that injection maybe. Nobody goes to jail. You're not forced to jail. You're forced to treatment. So I'm Lauren's partner. So when Zane died, I do what I do, which is research. I started researching and reading like crazy. And I saw in a couple states they have a law like this. It's called Casey's Law, Jennifer's Law, where basically family can go to the court for this person who can't make the decision on their own or don't recognize they need treatment. They can go to the court and ask the judge to make a decision, and they'll undergo evaluation by substance abuse and by a mental health counselor, and they'll decide. So in New York, is anything like that? going on in the assembly, and what is the panel's thoughts about something like that? Just curious to get your feedback.
Okay, well, I'm not familiar, but go ahead.
So I think part of what you're talking about is civil commitment for folks, civil commitment, and, well, guardianship. So Drug Policy Alliance is against any form of coercive treatment. We don't believe that folks, because what they fought for in New York State was the ability to do the 48-hour hold, and then they fought last year and they won, and we fought against them increasing that from 48 hours to 72 hours, because usually what happens and what research has found is that when folks are mandated to coercive treatment like that because their families obviously who are struggling and want their loved ones to get into help go in, when they go out, the risk of overdose skyrockets. Because once people are able to leave, if they are forcibly committed, then when they come out, they're going to want to use, and the overdose rates skyrocket. So we don't support that.
If I could, we do have experience with that. Family court system is filled with requirements of parents who are have drug issues, losing their children. And my experience, I was a law guardian in family court for some time. The forced rehabilitation doesn't work. The fact is that even the strength of a parent wanting the return of their child is not enough for most parents to be able to deal with a clean drug. And what ends up happening is that they end up going into a cycle that's even worse, and then eventually losing their children. Now, I applaud you for what you did. And I think individually there are a lot of people that can do that, the threat, or the fear of a felony, or whatever the story is. But we're talking about a condition, a medical condition, which is not a rational decision that's being made. And so what happens is looking for a rational solution by having a felony standing over your head, or some other kind of forced or coerced rehabilitation generally does not mean well for that rehabilitation.
Okay, well, I think most of my questions were answered, and I know there may be others that have questions, but we can continue this conversation. Ladies and gentlemen, panelists, audience, thank you so much for this rare and informative discussion. That is all the time we have. We were going to stop now to give the audience and the speakers perhaps an opportunity to intermingle. And by the way, there's something else that is happening in the back about Narcan. I think there's a demonstration back there. So thank you so much, and we can continue the conversation. Thank you. Thank you. Absolutely.